Well, hello. Good morning, good afternoon, good evening, good night, wherever you may be. It is my absolute pleasure to welcome you to this session today called End Inequalities, End AIDS, End Pandemics. I am your moderator for today. I'm Peter Hayward, editor of The Lancet HIV, a journal dedicated to publishing research and opinions to advance the HIV field. And it's really my great pleasure and honor to have been invited by the hosts of today's session to moderate. The hosts of the session today are CAPRISA and the Chinese CDC, and they've really put together a fantastic set of speakers who are going to talk to you today about HIV, reflecting where we are in the fight against HIV today, the past 4 decades, reflecting on that and reflecting on the future. And also, obviously, we'll be reflecting on the past couple of years as well, and the impact that coronavirus and COVID-19 have had, and the interplay between HIV, AIDS, and this new pandemic. As I said, we've got a fantastic list of speakers today. We're going to hear from Adiba Kamarulzaman, Peter Piot, George Gao, John Nkengasong, Sibongile Chabalala, and also from Professor Salim Karim. Before we start with the speakers, before I introduce the first speaker, we are recording the session today, so if any of your colleagues can't make it, you can always tell them to check it out later. It will be aired on the CAPRISA YouTube channel. And we'd really like for everyone who's watching today to get involved. You can use the chat and comment functions to share your thoughts on the speakers' talks as they're happening. And also, we'd really welcome any questions that you might have for our speakers. So please use the Q&A function, and we will have a moderated a question and answer session at the end of the talks. So now it gives me great pleasure to introduce our first speaker. Our first speaker is Professor Adiba Kamarulzaman, Professor of Medicine and Infectious Diseases at the University of Malaya, Chairwoman of the Malaysian AIDS Foundation and President of the International AIDS Society. Adiba is going to be talking to us on HIV, Follow the Science. So let's hand over to Adiba and see what she has to say.
Good evening, and thank you very much for inviting me to speak at the World AIDS Day webinar today. My name is Adiba Kamarulzaman. I'm from the University of Malaya in Kuala Lumpur, Malaysia, and President of the International AIDS Society. I'll be speaking this evening on HIV, Follow the Science. From the release of the viral genome in January 2020 to modeling the non-pharmaceutical interventions and restrictions that impact national policies, to finding effective treatment for severe disease, and more recently, repurposed drugs and novel treatment for acute and early infections, we have witnessed the amazing power of science to turn around the COVID-19 pandemic that has wreaked havoc across the world. And of course, it has been a dizzying year for vaccine science that has resulted in some taming of the pandemic, although we still are not out of the woods yet. Certainly in Malaysia, where we witnessed a horrific surge of the Delta infection between July and September of this year, it was only upon the arrival of the vaccine and scale up that once it surpassed 50% of the population, it's now at about 90% of the population, did we finally manage to get some relief from these horrific scenes that we were witnessing in our emergency departments, in the COVID wards, and in intensive care units all over the country. It was on the back of this amazing scientific endeavor and achievements for the SARS-CoV-2 and COVID-19 pandemic that the IAS decided to put out a clarion call in our annual letter to follow the science in this, what Croatia very nicely put as last 100 miles to end the AIDS pandemic in a recent meeting that we both attended for you and AIDS. As we saw in the several decades of the HIV pandemic, the know your epidemic, know your response that became the mantra for the HIV response continues to be an important strategy for responding to pandemics, whether it's HIV or COVID-19 response. And we have seen the world over that knowing your pandemic and following the science can give rise to great outcomes, whether it's in COVID or in HIV. Now, here's an example of where nations understand the nature of their pandemic, in this instance, in Ukraine, China, and in Malaysia, where we were witnessing increases in HIV incidence due to injecting drug use. The implementation of harm reduction resulted in a reversal of the pandemic in Ukraine, in China, and in Malaysia. The opposite would happen if these evidence-based intervention programs are not implemented, as has been seen in the Philippines and in countries of the former Soviet Union. Following the science not only saves lives, but it also saves money. As you can see from this slide, the evaluation that we carried out on the harm reduction program in Malaysia saw savings of millions of ringgit in direct healthcare costs for the Malaysian government. But we need continued investment in new tools and invest in research and continue to invest in research and development in HIV if we are going to bring an end to AIDS. There's been no doubt a disappointing setback from recent advances in HIV vaccine research, but we look forward to results of Mosaico with anticipation and further trials in regards to HIV vaccine technology. New tools such as the discovery of new broadly neutralizing antibodies for HIV prevention is now in very active field of research with at least 11 studies underway, most still in phase 1, but there are 2 in phase 2. And once again, we look forward to much development in this exciting field. Advances in treatment have also seen simplification of treatment regime from single pill doses to 2-drug regime for treatment and dose simplification. This have no doubt led to better quality of life for our patients living with HIV. More recently, research in long-acting injectables or pills will continue to improve the treatment landscape for people living with HIV and perhaps be a game changer in how we manage patients with this chronic disease. Certainly, we must continue to invest in cure research. But a little worrying is that we have seen a plateauing in funding related to this research program. As you can see, HIV science has remained active despite the attention that, rightly so, has been given to COVID research. And we must continue to find new ways to implement the tools that we already have from, like I mentioned, needle syringe program, which remains, and opioid agonist treatment that needs to be scaled up. But we also have a not so new tool in the form of PrEP that is entering its second decade. Although the uptake of PrEP has been rather slow since the since the clinical trials confirming the effectiveness of PrEP, fortunately, in the last few years, we're seeing more and more countries adopting this effective prevention tool. However, I think it remains to be seen, although adopted into national policies, whether PrEP will be scaled up effectively to bring about a reduction in new HIV cases around the world. A fine example of PrEP scale-up has been in Australia. In 2016, before 2016, the remarkable HIV response that we've seen in Australia for decades saw a plateauing of new cases of HIV in that country. However, with a concerted effort to scale up PrEP, which initially began as a large implementation science program in 2018, which then was absorbed into a national program, the Australians have now seen the fruits of their success, with a sharp decline in the number of new HIV diagnoses in Australian-born MSM, factored at 42% decline, and a 75% decline in Australian-born men living in the inner city. In the setting of affordable PrEP that is now being rolled out in Australia with associated healthcare services, Australia has witnessed very low HIV incidence of 1 to 2 per 1,000 person years amongst gay and bisexual men who were previously at high risk. Now, what has Australia done right that has not been seen in many other countries around the world? I think one of the defining features of the Australian response right from the beginning is its high-level political support and targeted response to HIV, together with a highly functional primary care system or universal health care. And in the case of PrEP, being offered at a relatively low cost, but with the provision of generic PrEP, coupled with quality monitoring and evaluation and timely data, and importantly, the involvement of people living with HIV and people affected by HIV, and by and large, the very HIV literate and mobilized gay community. So, ladies and gentlemen, in the last 20 years, we have witnessed the power of science. We have witnessed, although the COVID pandemic is far from over, we have now an amazing array of diagnostic tools. We have effective treatment for severe disease and promising treatment for early disease, not to mention, of course, the vaccines. Over the last 4 decades, we have also witnessed how HIV has become a disease that killed more than 36 million people to a chronic manageable condition and a highly preventable disease. Our challenge is to implement these evidence-based tools for both prevention and treatment that we already have to scale. As we have witnessed time and again, it takes a lot of science, but it also means dealing with politics, ideology, and sometimes plain ignorance, as was said by Ken Buse and Michelle Sidibe and Claire Dickinson in a paper back in 2008 when they were discussing the Know Your Epidemic, Know Your Response strategy. HIV response works best when we all come together, clinicians, scientists, researchers, community workers, people living with HIV and affected by HIV, and of course, policymakers and funders. Let's be encouraged and inspired by COVID science to push the extra few hundred miles to end AIDS by following and expanding the science that we have all built together over the last 4 decades. Thank you.
Well, that was just a fantastic global overview of where we are with HIV science at the moment, and how tying together sort of the many different aspects of the HIV response can make a real difference where there's political will to follow the science and drive to do so. Thank you so much, Adiba, for that fantastic opening talk. It now is my great pleasure to hand over to Peter Peels. Peter is the Handa Professor of Global Health at the London School of Hygiene and Tropical Medicine, and a special advisor to the European Commission on research innovation for COVID-19. And his work from the discovery of Ebola in the 70s to work over the past 4 decades on HIV really is testament to his drive, and many wonderful achievements. So, as I say, it's an absolute delight to welcome Peter's discussion on AIDS from epidemic to endemic, the importance of a long-term perspective. Let's hear what Peter's got to say on that.
Hello, everybody. There's no doubt that we've come a long, long way when it comes to the response to AIDS. And it's always good to remind us when we are struggling with all the difficult issues on a day-to-day basis. And the question, of course, is where we're going. And here you can see the evolution since 2000, but let's not forget that this epidemic has been with us for at least 40 years when AIDS was described for the first time. It is less acute in most populations than before, but also the progress that was quite spectacular in the the 2000s, and particularly since the introduction of antiretroviral therapy, that progress has really slowed down. And it's very clear that we will not reach the UN goals, and that was already the case before COVID hit us and made it even worse. And it is so that, despite all this effort, when you look at sub-Saharan Africa, for example, that HIV/AIDS is still the main cause of death. So it's not that it's marginalized, even if it's off the headlines. And we're going to a situation where, where there is increasing heterogeneity in terms of among countries. Some countries are far more affected, thinking particularly in Southern Africa, but also like some of the former Soviet republics. And then, of course, within countries, certain populations. And here you can see quite a big difference between when you look at just sub-Saharan Africa, which, by the way, is definitely not a homogeneous type of continent in general, but also when it comes to AIDS, and the rest of the world, who is becoming infected. And there's a huge difference. Sub-Saharan Africa, it is mostly, young women, young men also, and whereas in the rest of the world, it is very specific populations, men who have sex with men, drug users, etc. And so we are coming in a situation where not unsimilar, dissimilar when we talk about COVID, where rather than to talk about the end of AIDS, as is still the official rhetoric, and with even a date on it, and I think we have to start thinking what to explain and what to do when we don't reach that. But it's like with COVID, we have to set aside and zero COVID, and we have to think about living with HIV as societies. Of course, we have people living with HIV, and 30 plus million, and they know what this is all about. But as societies also, we have to do it. And when you look at the whole picture, and this is one indicator of it, AIDS is off the front page, and that's reflected in many aspects, including funding. This is from the IHME latest update on the national funding for AIDS, but national funding has collapsed even more than that. So the future really will depend on a few things. One, of course, we had the great disruption, which is still going on in terms of COVID-19, and which has negatively impacted the care for people living with HIV because of supply issues, also prevention programs, even research, clinical trials, just name it. It's of course not specific for HIV, but it is a real fact of life. But the future will depend on many aspects, the future of AIDS. It's of course on whether this kind of disruption will continue, and there will be others coming, which is quite likely, but it depends on the virus. Will the virus develop resistance, on people's behavior, technologies, leadership and politics, prosperity in general, demographics, etc., etc. And about 15 years ago, I launched a project when I was head of UNAIDS that was, about AIDS in Africa, the long-term future. We were looking at 2025, so that's around the corner. And because I felt that we need this long-term view, because it's important that decisions we take today, even in the midst of a crisis, that at least we have some idea and some vision on what the longer-term implications are. And at the end of the day, again, we want a long-term, sustainable response that benefits people and saves as many lives as possible, not just in the what's going on today. And then also about 12, 13 years ago, I launched a so-called AIDS 2031 consortium, and that issued a report, AIDS Taking a Long-Term View, for the same reasons, trying to look into the future and to see what is feasible, what is, what should we do, where should we invest, and so on. Next, so the long-term view is not something new, but I think now we have to make sure that it is on the agenda as much as managing a crisis. When this came up, some activists accused me of wanting to defer much needed, measures immediately, but that, of course, can never be the reason. We have to make sure that this benefits the most people possible all over the world, including the most marginal ones. And the long term is really already getting clearer and clearer, in the sense that we've moved from an epidemic to an endemic. Again, bit of deja vu when we think of where we're going with COVID and with coronaviruses in general. And these are some quotes from the these two reports I mentioned. And in 2005, the report on AIDS in Africa, which involved well over 100 people from Africa involved in the AIDS response, and it said AIDS is not a short-term problem. Whatever is done today, the decisions taken now will shape the future history of AIDS. So that's the reason why we have to think of that. And then the AIDS 2031 report, which came out in 2011, said also, pandemic is not going away, but its magnitude and severity can be dramatically curtailed. We need to adopt a long-term perspective and recognize the pandemic for the generation-long challenge that it is. So we're in this for the long haul, and that is now clear. And that has many implications, and many implications organizationally, etc. But besides the negative disruptions that I mentioned, I mean, COVID, but also a decline in leadership, etc. And because COVID has not only affected operations, but also, for example, when you hear UNAIDS, they mostly talk about COVID, not about AIDS. So it's a leadership issue and impact of COVID. But there are, in terms of the the future. And in order to do better, on the one hand, sounds boring, but we need to do a lot more of the same. It's not that we have to throw away what we've been doing. We need a lot more of the same. Prevention programs, combination prevention, ensuring long-term care and therapy for people living with HIV, fighting resistance, which disappointingly, frustratingly, continues to be there. All that is necessary. But we also have to make sure that, you know, we ride on innovation, because innovation offers the hope for a qualitative jump forward and difference, as long as three things are in place. One, of course, leadership. Two, the money, funding. And three, that with innovation, we reach the right people. There are now enough papers of introducing, be it pre-exposure prophylaxis or other preventive measures that are fairly successful on first sight, but we don't reach the people who need it most. We reach the people who come to health services, for example, but these are not necessarily the ones where the infections are. And, you know, so this is where we need to make sure that it's not only continuing this technological innovation. And what is very exciting is, of course, it's like long-acting therapy and probably also long-acting prevention, like the cabotegravir and nilpivirine, long-acting injections. And I think we could go to something that, like with 4 injections a year, we can keep the virus under control, both in the body and perhaps also preventively. Female-controlled prevention measures. And one of our co-hosts, Slim Abdul Karim and Quresh Abdul Karim, have been pioneers in this field. So that's one thing. Secondly, and in terms of this technological innovation, let's not forget that we need to continue to invest in vaccine development, despite disappointing results, even recently with the Janssen HIV vaccine. Also, we need innovation in prevention. There have been, you know, good initiatives, interesting, like in, you know, in Kenya, in KwaZulu-Natal, in some parts in, you know, all over the world, where more precise data have been used to adapt prevention programs to the needs of people. And it's a combination of qualitative research, listening to what people have to say, working with the communities, but also have very sophisticated quantitative data from genomics to see how the transmission works, to demographic data and so on. And then another innovation that I think we need to use more is to go beyond the health sector. Innovation in communication, reaching people, you know, young people, like the MTV Sugar programs, which have been adapted now from Nigeria to Kenya to South Africa, Cote d'Ivoire, India. And that's as important as having the right messages. But thinking of who do we want to reach and what is going to be the, you know, what do we want to achieve and what's the best medium. And here, you know, the final innovation, I think, is we talk a lot about, you know, societal enablers, structural interventions, but there, that has kind of disappeared from the agenda, including, of course, fighting discrimination and so on. But we need to think again outside our health box, because it can make a difference, as these projections coming out of UNH report demonstrate. Now, to end, what's the way forward? Where to go? First of all, I mean, I think we need to rethink the narrative of HIV/AIDS. On the one hand, it's clear that it really disproportionately affects many discriminated and, you know, marginal populations. On the other hand, you know, if we position HIV as only an issue for the most marginalized and discriminated, you know, that's not only wrong epidemiologically, as I shown earlier on in many countries, but also it really, you know, is counterproductive, because it will push AIDS to the margins, and we can forget about leadership, political leadership and funding and so on. So, but we need to rethink the narrative in times of COVID and beyond. Secondly, we need leadership that is unashamedly committed to AIDS and not trying to talk about other things all the time. No, this is about AIDS. It's still the first cause of death in Africa, for example. And it's still killing every year, 700,000-800,000 people. This is not a detail. Thirdly, we need to revitalize activism. When I go to some meetings and on AIDS, I see the same people I used to see 20 years ago. There's something wrong with that. Making sure there is activism as the beating heart of AIDS response. Fourth, the brilliant coalition that made such a big difference, for example, in South Africa, but also elsewhere, we need to rethink where are the coalitions and how to do that. And that may be different from one country to another. Fifth is, we need to rejuvenate the strategy adapted to the new realities on the ground, new funding realities, but also new demographic realities, and, and deploy these innovative tools that I mentioned. Six, maintain research, be it the genomic research to understand transmission, to new vaccine and new tools. And finally, it's delivery that, is going to make the huge difference. And that will require also thinking through operational synergies. We've been talking about combining TB and HIV for a long time. Makes good sense, but it's often not happening. Integrating or not in primary healthcare and systems, but making sure that we reach those who are in need. So to end, let's not forget one thing. And that is that AIDS has always been about politics. And we need to ask our question, who's in charge? Who's in charge in a country? Who's in charge in the community? Who can be held accountable? And as scientists, as public health experts, let's make sure that we also are, players in this political field, because that's how we will get the commitment, the resources, the innovation, and of course, the communities on site. Thank you so much for inviting me to this wonderful initiative, bring together China and South Africa and Africa and the rest of the world, because that type of global solidarity is what is absolutely needed to defeat AIDS.
A great talk there. I was really struck by the idea of bringing innovation, taking innovation and looking at taking the long-term view of how that innovation is deployed. So thank you very much to Peter Piot there. It's now a great honor to hand over to George Gao. George is a Director General of the Chinese Academy for Disease Control, Chinese Center for Disease Control and Prevention, and Vice President of the National Natural Science Foundation of China. Professor Gao is also Director and Professor of the Chinese Academy of Sciences Key Lab on Pathogenic Microbiology and Immunology. And Professor Gao is now going to talk to us about HIV in China. Let's hear what Professor Gao has to say.
Hello, everyone. Good morning, good evening, good afternoon, wherever you are, whenever your time zone is. I'm very pleased to be here for this World AIDS Day webinar to present my talk on HIV in China. I'm the Director General of China CDC. So I'm going to talk in four aspects about the HIV in China: the situation and response, and the epidemic at the moment in China, and our progress for the response. And also, with one slide to think about the challenges in China at the moment for the AIDS response. So, AIDS is something special. To control, to get the AIDS down, definitely you need a strong political will and strong leadership. So in China, in general, we have a very strong leadership and political will, including our President Xi Jinping, our Premier, and also our Vice Premier, Mrs. Sun Chunlan, our Premier Li Keqiang. They all, very actively participated in the activity. So this is why, to get the AIDS under control, the government role is very, very important. So the government and the administrative department, they really play a very important role in China. So in the State Council, we have a State Council AIDS Working Committee, which was established in 2004 and consisted by the members from 34 ministries and 11 provinces, autonomous regions, and municipalities. And they are responsible for developing the national policy, guideline, and action plan on the response. And they are also coordinating the nationwide crucial issues, mobilizing the coordinate administration and the social resources and the activities of the AIDS response. So it's very, very important to have this HCAWC. And more than 40 policy documents over AIDS response have already been issued already. It's related to legislation, financing, human resources, public security, education, civil affairs, etc. And similar coordinating and mechanisms have also been established in the mechanism in the provinces and prefecture and county level. So this is very important for this political will. Of course, you have to try to get everybody actively involved. So public involvement is very, very important. So we have China AIDS Fund. So the AIDS Fund for non-government organizations, they donate a lot of funds to support for this, not only for the research, but also for the activities, very actively involved inside China. So for that, I want to address a very important role for the community level control. I was invited by the Lancet Public Health during the COVID-19. We are still experiencing the COVID-19. So what's the major, achievement or major base for China to achieve such a good achievement to contain the COVID-19? So in my opinion, the public health at the community level is the key. So I wrote something for the comment. If you have interest, you can go and read this comment in Lancet Public Health. Strengthening public health at the community level in China. So that's very, very important. So what's going on for the epidemic at the moment in China? So at the moment in China, sexual transmission drives the major HIV epidemic. You can see from this figure, it's so clear, 97.5. That's a big number. They are because of the MSM heterosexual transmission. So that's getting important in China at the moment. And also, you have an imbalanced distribution of the HIV epidemic in different areas. Look at the regions. You can see in some regions in the West, in the Southwest, these are the most serious region there. This is why we put a lot of effort in that area. We will address a little bit more further later. So the testing capacities in China, while we have an epidemic, the HIV and the AIDS is very serious in China, and we are working very hard to get all the answers from science. Getting the answer from the science is very, very important. By increasing all these screening and confirmation laboratories in China, you look at this figure, both screening lab and confirmation lab, the numbers of the lab in the whole country, it's increasing. So we almost covered everything at the moment. So this is why, in general, though I will show you 1990, 93, 90s, we haven't covered all of them, but we are near there and with a good numbers here. Of course, active HIV screening in China and increased very quickly. Look at all these numbers, these meetings, and also the percentage. You are talking about roughly about 20%. We covered for all this screening nationwide. That's a very good number. That's not an easy number you could get. So that's a very important part in China. For HIV, it's different from the any other acute disease, including COVID-19 or flu, because they are it's a chronic disease. So it's very difficult to find the virus. This is why the screening in the population is the key. And also, this social organizations, non-government, social government, and they really help for this all this screening of the HIV testing. Because this is China AIDS Fund. They with non-government organizations, they did all invest a lot of money here. So it's very, very important in China. Interventions. In the left side, you can see for especially for the occurrence in the illegal drug user at the moment, it's getting much better at the moment. And also for the MSM and all this, you can see all this number, they decreased a lot, for the last few years. Of course, for the antiviral, antiretroviral therapy. So at the moment in China, we are running a very, very active program here. Of course, in China, the initiation of the ARV is very late, not very early. But after that, you can see at the moment we covered as much as possible in China at the moment, especially for some of these lower CD4 count individuals. So this is give you an example. You see dramatic increase for the antiretroviral therapy between 2004 to 2020. You see, this is the number is in thousand. You can see, you whole China. It's for the last decade, it's increased a lot. That's plays a very, very important role. And also by using this antiviral coverage and viral suppression, you can see the rate. You look at this, it's almost level off already here. So this is, you general. It's we in China we achieve a lot. However, look at this 90 so-called 90 programs. We still have a little problem with the people living with HIV who know and who has no idea. But in general, if all those HIV positive personnel are recognized or found, usually this coverage is relatively good in China. You're talking about 92%, 0.9, and also for the treatment, you are talking about 96. You can see this is very important for the first financial support, a second active involvement from the doctors, and third political will. Political will, I always think is the key for some disease control like AIDS. Of course, we need some new technology. In China, we also adopted the PREP. By using PREP, we also try to use the internet intervention by using so-called social vaccines, to try to educate or try to get the people understood why HIV is here. And it's very important to have HIV self-testing. So now we have some self-testing kits in China. It's popularly in a vendor machine, in the vendor machine, you can really buy that kit. So this can show you this, example with all these soft drinks. You can buy soft drinks there. You can have a self-testing kit there. So you can see the online selling here. It's it's a good form and moment in China. And also we are doing the HIV molecular testing network. So we try to collect as many as possible all the data, especially for the antiviral mutations. So we have all this because this is also very important for the targeted intervention. And we also try to put the poverty eradication together with the HIV response action. So what we did in Sichuan province, that's in the southwest China, for Liangshan. So there we tried very hard, to get all these measures to be there. Especially we summarize our action. We call it the innovative 1+M+N. 1 means leadership, the political will. M means is the health staff or professionals to be actively involved. And N is numerous volunteers in the villages and in the community level. You needed all these volunteers to help us to set up all these, testings and also the treatment. And if this is during COVID-19, we also encountered the problem with the ART treatment. So we are ART interruption during COVID-19. We still, we tried very hard, but we also call everyone should really realize, because of the lockdown, because of suppression and COVID-19, you might have some problem with the epidemic of the AIDS and the treatment. Finally, this is the challenges ahead in China, in the world. First, no effective vaccines. It's not really in China. That's a global problem in the whole world. We don't have effective vaccines. In my opinion, we need to keep asking the answer from science. We need to invest more in the basic science, whether more in the basic research. Maybe one day we will understand well about the virus, understand well about the disease, and then we might be able to get an effective vaccine. And also we need something, radically curative drugs. You need really eradicate this virus. That's our target. And second, sexual transmission dominates the epidemic at the moment in China. So we need, really with a social vaccine, try to educate or try to get the public understand, what's going on and the whole serious the HIV. But in general, in China, we have a very steady epidemic, relatively steady. It's relatively controlled well. And also in China, we have MSM is another serious problem at the moment. Like I showed you earlier, 390s. We have the first problem for the 90s, not 90 there yet. So always you have a late diagnosis. That's very, a serious problem. And for PREP in China, I mentioned it's just implemented. And it's initial stage. We need to work harder to make sure we can get it done. So in general, so this is a challenge ahead in China. I hope we can collaborate with you and get some good answers. So this is the World AIDS Day, what we need to do. So the slogan, let's work together, end inequality, end AIDS, and pandemic. Now, since we are together here with South African colleagues, so I'm calling here, by following the 4C principles, let's work together. We need the cooperation. Meanwhile, we also need the competition, because competition, cooperation, they are twin brothers and twin sisters. They will help for the development of the science and technology. Let's work together. We also need to keep communication. We also need to do some coordination. So this is something I wrote with John and Kangasol in Lancet Global Health. So we call public health priorities for China-Africa cooperation. So we, with John, we put these 4C principles for the future collaboration. I hope we'll have a good collaboration with South African colleagues. Let's work together, get the AIDS down. Thank you very much.
Thank you so much, Professor Gao. That was a great overview of the situation in China. I was really struck by the thought of having HIV self-testing in vending machines, which is a great innovation to improve accessibility. I would remind everyone who's listening to the session today, who's joining and enjoying the talks, please do post your questions to our speakers in the live question bar on the platform today, and we will have a session at the end where we can put your questions to the speakers and get live responses from them. So we just heard about the partnership between China and Sub-Saharan Africa there, and Professor Gao mentioned our next speaker. It's a delight to introduce John Nkengasong, whose work in HIV and other infectious diseases led to his appointment as director of the African Centre for Disease Control and Prevention, which has been in which he's done great work. And more recently, John has been a special envoy to the WHO Director General on COVID-19 preparedness and response. John is going to talk to us now about HIV in Africa. So let's hear what John has to say.
Greetings from the Africa Centers for Disease Control and Prevention. And I'm extremely delighted to have been asked to contribute to the World AIDS Day in 2021 by commenting or making a few remarks on the epidemiological trends of HIV in Africa. I will, in the next couple of minutes, go through the trends and look at the global trends of the pandemic. And I use the word pandemic very deliberately, and then focus more on what the trends we are seeing on the continent for the last couple of years. This is a busy slide, but it shows you three things. One is the number of people living with HIV/AIDS cumulatively, which is about 37.7 million people. The people that are newly infected with HIV/AIDS, HIV in 2020, which is about 1.5 million people globally. And then the AIDS-related deaths in 2020, which is about 680,000. I'll go into the details, as I said, with respect to the African region. If we now look at the continent, every day there are about 4,000 new HIV infections in adults and children in 2020. 60% are in sub-Saharan Africa, 10% are amongst children under 15 years of age. 90% are amongst adults aged 15 years and older, of whom 51% are amongst women, 51%. That is a disproportionate burden in women. 31% are among young people and 20% are amongst young women. If we now look at the regional HIV/AIDS statistics and future in 2020, you look at and compare a few regions. You look at East Africa region. Let me first of all just explain what the colors are. The green colors are the adults and children living with HIV/AIDS. The blue are adults and children newly infected with HIV. And the orange color are adults and children deaths due to AIDS. So if you now look at the region, the Eastern and Southern African region has the disproportionate amount of people living with HIV/AIDS, about 20 million. And then the West and Central Africa, about 4.7 million. And in Middle East and North Africa, about 0.23 million people. There's about 230,000 people. The number of adults, as you can see, and children estimated to be living with HIV/AIDS since 1990 to 2020. Clearly, here you see the adults and estimate. The light greens you see there are what you call the range of uncertainty, but clearly, of course, how the cumulative number has increased, as you can it can be rightly justified because of people are living longer because they are on HIV/AIDS treatment, which has been scaled up, and I'm sure we'll discuss this in the subsequent slides. This slide shows you the number of adults and children estimated to be living with HIV/AIDS in 2020. First of all, on the left-hand side, it shows you the map of the world with an estimated 37.7 million people living with HIV/AIDS with a confidence interval of 30 million to about 45 million. And it clearly shows you the disproportionate impact of HIV/AIDS in Africa, especially in sub-Saharan Africa. On your right-hand side, it shows you the people living with HIV/AIDS by region between 1990 and 2020. And it is remarkable that the orange line you see up there is Southern Africa, and it's really distinguished in terms of the impact, the disproportionate volume or number of people living with HIV in that region. If you look at the number of adults and children newly infected with HIV between 1990 and 2020, you clearly see that it has been steadily decreasing, but we are not yet where we have to be. That is decreasing between 1990 and 2020. Again, the thick green color shows you the adults and children newly infected with HIV/AIDS, and the light color is the range of uncertainty. This slide shows you the estimated number of adults and children newly infected with HIV/AIDS in 2020, but I would like to focus more on the right-hand side, which clearly shows that the efforts that are going on across the Africa, different regions of Africa, is paying. You can see the orange color, which is the Southern Africa and Eastern Africa, how the numbers have decreased steadily. But in other regions like Western Africa and Central Africa, the decline has not been as remarkable as in other parts of Africa. And this is again just to show you in the picture of adults and children, the child deaths due to HIV/AIDS between 1990 and 2000. It's remarkable that in 2005, that is where ARVs have been scaled up in Africa and it started showing an impact. And you can truly see the correlation between that scale up, which started around the early 2000s, and then where the curve started bending, coming down nicely, showing the impact of an intervention, an effective intervention in managing an HIV or an endemic disease. This graph then shows you the different regions, comparing the estimated number of adults and child deaths from AIDS in 2020. I mean, again, it mirrors the previous slides, dramatic decreases in Southern Africa and Eastern Africa, but really kind of stabilizing. The decline in West Africa and Central Africa is not as profound as you see in the Eastern and Southern Africa. Now, let's look at the 40 years history of the AIDS response, characterized by remarkable discoveries. In 1981, as we know, the United States Centers for Disease Control and Prevention reported the first cases of HIV. And in 1980, as you can see there, HIV was characterized and defined. And then in 1987, the first therapy for AIDS, the zidovudine, was approved by the US. Fast forward in 1988, very important clinical trials showed that we can reduce, or we could reduce, mother-to-child transmission. And then in the year 2000 or so, the African Union member states, 2001, committed to allocating at least 15% of annual budgets to improve the health sector. In 2002, the Global Fund to fight HIV/AIDS and malaria was created. And in 2002, also about 300,000 in developing countries in treatment, started seeing the impact there. But fast forward, you can see where in the whole spectrum over the last 40 years, the response has changed. And clearly, we are now at a point where who could have imagined that in 2020, about 27 million people would be on HIV treatment. And now we have a new global AIDS strategy with focus on ending inequalities to end HIV/AIDS epidemic. That strategy has been adopted by the United Nations AIDS program. This slide shows you amongst people living with HIV, the percentage who know their HIV positivity status, receiving treatment, and are virally suppressed. And you can see on your left-hand side that about 84% of people who knows their status, about 73% of people who knows their status are actually receiving treatment, and 66% of people who have been diagnosed and on treatment have viral suppression. This is data from UNAIDS in 2021. And on the right-hand side, it shows women and men. You compare that number, the same breakdown of the total population by gender. You clearly see that the bar with women, that is, tend to do better than men across the board, whether you're dealing with people who knows their status, or those who receiving treatment, or those who have viral suppression. That is an clear area of work. Whereas, yes, the burden is in women, but we see that unless and until we are very specific and focused on the men's issues as well. We'll continue to have that gap and inequality in treatment, viral load suppression, and knowing their status. This slide shows you ART coverage by region, and very clearly the eastern and southern region clearly showed a remarkable progress. Western region and Central Africa region, they show 61% and 68%. That is where a lot of work needs to be done in those two areas. I'm very pleased that just 2 weeks ago in Dakar, Senegal, UNAIDS actually convened a meeting to look into the details and a deep dive of what the situation is in those two regions. This slide, I will not go into the detail. It just breaks down the ART coverage by different regions. I will leave you to digest that, but it's just unpacking what has happened in the different regions between 1990 and 2020. So ending the HIV/AIDS pandemic by 2030 will require that, of course, we look into key fast-track targets and how do we enforce the 90-90-90, which truly has been revolutionary in the way in which we address the HIV pandemic, and how do we sustain this and address those gaps that I showed in the previous slides. This is for an example of countries reaching the 90-90-90 HIV treatment target in 2020. Clearly in green are those who reach those who reach the 90-90 targets, and then in light green are those that reach only the 73% viral load suppression, and then in, of course, orange color are those that have not reached the 90-90 targets there. Again, the idea here is not to shame a country, but rather to raise awareness. For example, countries like Eswatini that have just are green all across the board. Rwanda is doing great, except in the areas that in children. So this kind of a graph and projection is designed to encourage countries and partners to focus on where the burden of the disease and where we are struggling in order to support countries to get to where they have to be. So the Global AIDS Program, UNAIDS, has launched the End Inequalities, NAIDS Global AIDS Strategy, which the Africa CDC is totally adherence to. It talks about a zero discrimination, zero new HIV infections, and zero AIDS-related deaths. And that is the way that we should be targeting to end AIDS as a public health threat by 2030. And there are cross-cutting things that must be covered in this strategy. They include strong leadership, country ownership and advocacy, partnership, multi-sectorality, data, science and research, and very importantly, innovation, stigmatization, discrimination, human rights and gender issues, and then the city urbanization and human settlements are all factors that will play a role in the way we reach that target by the year 2030. This is also a slide that shows you how a pandemic can impact our HIV response very clearly, and how the percentage change in number of people receiving ART compared to baseline in January, February of 2020 has been disrupted by the COVID-19. We need to factor that into our response, the emerging and re-emerging infections. This is the COVID-19 disruption in HIV services, percentage change in number of tests across different countries in Africa. And let me just, as I move to conclusion, also just point us to the threat that the global HIV drug resistance poses on our ability to reach our targets. And we also have to keep an eye on and a focus on the drug resistant issues that especially amongst naive patients in the world. This slide shows you the progress in transition to the DTG as a preferred ART regimen in low and middle income countries. And I think clearly a preferred first-line regimen among adults and adolescents in low and middle income countries. We continue to believe that new innovation will enable us to come out with new drugs and new approaches that will facilitate delivery. So again, as I conclude, let me just leave you with 3 key messages. AIDS has come a long way since the first cases about 40 years ago, in that a uniformly fatal disease has been transformed into a chronic manageable condition through global solidarity, through programs like the Global Fund, PEPFAR, and other global solidarity mechanisms. HIV remains a global challenge where each one of us needs to take responsibility for reducing the spread of the virus, and that we must achieve ARV coverage in the world and ensure that we reduce gaps in inequalities and inequities. That is the only way we are going to together achieve our goal. I thank you so much for, again, including Africa CDC as part of this very important celebration. That is the World AIDS Day in 2021. Thank you.
Thank you so much, John, for that great overview of HIV/AIDS in Africa. I think it was striking how, you mentioned about the steady decreases in HIV metrics, but things really aren't moving as fast as we would like. So thank you, John. And again, between speaks, I'd just like to remind you to keep questions coming in through the live Q&A box on the platform. And we'll look forward to putting your questions to the panel later. And now it's my great pleasure to introduce you to Sibongile Shabalala. Sibongile is a national chairperson of the Treatment Action Campaign for South Africa, a board member of the Rural Health Advocacy Project, and a member of the Global Fund Country Coordinating Mechanism for South Africa. Sibongile is going to talk to us now about HIV challenges in the time of the COVID-19 pandemic. So let's hear what Sibongile has to say on that.
I'm Sibongile Shabalala, the National Chairperson of Treatment Action Campaign. I'm going to talk about the challenges in the time of COVID-19 pandemic. As South Africans, we know that since COVID has come, it has affected everybody's lives, not only South Africans, but everyone in the world. And we know that no one was prepared to deal with the issue of COVID. It has just came, and without any preparations to governments, to civil society, to communities. We started to see COVID-19 in 2020. And when we saw COVID, it has come in a time when we're dealing with a lot of challenges in our countries. I will be specific talking about what was happening in South Africa. We know that in South Africa, we have more than 7 million people who are living with HIV. And out of that 7 million people who are living with HIV, we only have 4 million people on treatment. And when COVID strikes, we're still looking at how are we initiating more people on ARVs. But COVID came and took all the attention from the HIV fight, from the other fights that we already have in the country. So what we have seen happening, it's when we saw people dying of COVID, but also those who are living with HIV felt neglected. Why I'm saying this? We know that many facilities, when we were under lockdown level 5 in the country, many facilities were affected by COVID, where 1 staff member or 2 staff members are infected with COVID. And when they were infected with COVID, that means that the facility needs to be closed. And when the facility is closed, that means patients are unable to access their treatment. But most thing that was challenging is that there was no communication to patients to say, today Clinic X is closed and patients who need medication, they can be taken to another facility or they can collect their medication from the other facility, which it made more people to default on treatment. And also as a country, as much as our government was saying they are ready to deal with COVID, but they were never ready to make sure that we maintain the standard of initiating people to treatment, of making sure that those who are on treatment are staying on treatment. We have written letters to the government to say you need to make sure that at least people have from 3 to 6 months treatment, so that people cannot default from treatment because of not having enough treatment. But that didn't happen, which it made it difficult for mostly people who living with HIV, which at the end of the year in 2020, we have seen about 20,000 people that we have lost in treatment in the country, which is very problematic, and which I think it has taken us back as countries. But also a commitment from the government in fighting HIV. That is still also problematic because we have seen less funding coming to fight HIV, and everybody now is focusing on COVID, which it's not wrong, but we shouldn't forget the problems that we have as countries, or the challenge of HIV. Remember, HIV is still killing people in the world. And as I'm talking to you here now, we have more than 1,000 young girls, especially in the African countries, in South Africa, who are infected with COVID every week. What does that mean? It means the fight against HIV is not yet over. And what we're saying to say we want to see to end AIDS by 2030, it means we are taking 10 steps back now. We are getting more people who are living with HIV, and at the end of the day, there are no services that they must are focusing on them, or there is less commitment from the Department of Health, from the governments, or from the funders who needs to support people on the ground. We've been talking about inequality, and inequality has been affecting mostly people on the ground. As people living with HIV, we have been seeing this for decades. Remember, now we are 40 years having HIV, and we've been dealing with this pandemic of HIV for 40 years. But up to today, we are still talking about inequality. We are still talking about people who cannot access treatment just because they are living in rural areas. We are still talking about people who cannot access treatment because they can't afford to buy treatment. We know that other countries like South Africa, we had organizations like TAC who fought for treatment and made sure that the government provides medication to people. But at the end of the day, we still see inequality, because when you go to facility and you are unable to buy your medication, then you have to wake up at 4 a.m. to queue for medication that you will get at 11 if the earliest, and sometimes you get it after 2 just for medication. But the person who's living with HIV, who can afford, who has medical aid, or can be able to pay for their health, they don't even have to go to the facility. The medication is either they go and collect it from the pharmacy or from the doctor, and it's even delivered on their house. So which it makes it easier for the person who can afford than the person who cannot afford. But also, if you look at how countries are responding to HIV, you find out that those rich countries are able to respond better than those countries that are unable to afford, or who are low-income countries. We have seen countries like South Africa, as much we have a high number of people who are on ARVs, but I'm still talking about half of the people who are living with HIV who are still on treatment. So that is inequality that I'm talking about. But also the communication, the way HIV is still treated. People who are living with HIV are still stigmatized. When you go to the facility, your card is still written, or you are still given another card with another color than other people who are living with other chronic diseases. So when we are talking about issues of stigma, discrimination, it's still the problem. And those issues, as much as we have tried to address them, but I think we have not yet dealt with those issues as we are supposed to. So what we are saying as people living with HIV, as we are heading to a World AIDS Day is that HIV fight is not yet over. We still have to fight. There is still lots that needs to happen. We are still facing the issues of stockout. We are still facing issues of people living with HIV who are denied treatment. We are still facing a challenge where people living with HIV, they don't have information. And also we are still feeling discriminated and stigmatized because of our statuses. So that is the message that I want to send to all people living with HIV, to say we still have to fight. We still have to take the burden and move forward, because the fight against HIV and AIDS, it's not yet over. Thank you.
Thank you, Sibongile. That was an incredibly passionate speech there, and really, you know, you really hammered home how those messages, which people have been making since the start of HIV, are still so important today, and highlighting why this session on End Inequalities, End AIDS, End Pandemics today for World AIDS Day is such an important session. Well, now it gives me great pleasure to introduce our next speaker. Our next speaker is Professor Salim Abdul Karim, an infectious diseases epidemiologist, director of CAPRISA, and CAPRISA Professor of Global Health at Columbia University in New York. Professor Karim is also a member of the African Task Force for Coronavirus, and certainly I'm sure a lot of us will have seen Salim on various outlets and news stories over the past few months speaking about coronavirus, and it's very reassuring, I think, always to know that Salim is working on coronavirus. Yeah, great pleasure to introduce Salim, who's going to speak to you today about COVID-19 and how COVID-19 has made HIV control even more critical and mapping the path forward. Let's see what Karim has to say.
Good day. It's my great pleasure to share with you today, in preparation for World AIDS Day, COVID-19, which has made HIV control more critical, just to give you some perspectives on mapping a path forward. What I hope to do is to deal with some of the key challenges that we face in HIV today, the limitations and the centrality of treatment, HIV prevention, dealing with COVID-19, before talking about some ideas on a path forward. So let's look at the pandemic today. If we're looking at HIV, in 2020, worldwide, there were 38 million people living with HIV, almost 700,000 deaths, and 1.5 million new infections. Africa accounts for about 70% of the world's HIV, with sub-Saharan Africa, about 1 out of 4 infections occur in young women. Professor John Nkengasong has touched on many of these, and he's given you a clearer sense of the challenges we face right here in Africa. Globally, we have almost 4,000 new infections of HIV each and every day. And overall, our global strategy is built on treatment for prevention, or TASP, treatment as prevention, as it's widely known, with the 2020 targets of trying to achieve 90-90-90. So let's look at how we've done on those targets. Well, not too badly. We have achieved 84, 87, and 91 at a global level. That's the current estimates from UNAIDS. We were supposed in 2020 to have achieved 73% of all people living with HIV being virally suppressed. We are now at about 7% below that. We are about 10% off that target, with 66% of people living with HIV thought to be virally suppressed. So we've had good global progress. Doesn't mean great. We haven't exceeded our target or hit our target, but we are pretty close. 14 countries have achieved the overall target of 90-90-90, and we've seen some uneven progress. In fact, in North Africa and in the Middle East and Eastern Europe and in Central Asia, we've seen much lower levels of overall viral suppression at 36% in North Africa and 50% in Eastern Europe. And we've got still a way to go to get to the target of 73% in those regions. But we are heading in that direction, and we are using new technologies to help us there. We have now new drugs with better safety profiles, we have simplified regimens, and we are moving towards a long-acting injectable approach. And we hope that these new technologies will help us get even further in that direction. Let's touch now on the limitations of treatment as prevention in terms of community impact. Ruben Granich and colleagues at the WHO showed many years ago in the Lancet that if you model the impact of treatment, you could end the HIV epidemic. However, when we look at individualized actual treatment studies in HPTN 052, we saw a wonderful impact. We saw how at an individual level, if you treat somebody, you reduced the risk that they can spread this disease. However, when you translate that into universal test and treatment trials, we've seen more challenging evidence in that we've seen little impact on HIV incidence. And as we've looked at these 4 trials that were undertaken in Africa, looking at how trying to roll out treatment and what impact it has on prevention, we've come to understand that antiretroviral treatment is no silver bullet. Its scale-up is essential, but not sufficient for epidemic control. And so we need to go beyond treatment as prevention. And we can see that here, that at a global level, we have been doing quite well with good progress on treatment. You've seen that in terms of our achievement of 66% on the way to the 73% target. But we are lagging in prevention. We've seen how from 2015 to 2020, over those 5 years, we moved from 1.9 million new infections to 1.5 million new infections, well above the target we had originally set of 500,000 in new infections only. We have quite a way to go to achieve our targets. And so how are we going to get there? Well, let's talk about those challenges in HIV prevention. At a global level, outside of Africa, we have seen key populations being central to the new infections. On the right-hand side, you can see how new infections in Eastern Europe and Central Asia have been increasing. And so we see that. We see that in the Ukraine, in Russia. We see that new infections continue at a pretty high rate in key populations, such as men who have sex with men and injecting drug users. But in Africa, what we're seeing is a general population challenge, especially in young women. So let's look at this challenge of HIV infection in Africa. You've already heard from Dr. Nkengasong the real problems we're facing, and the high rates of HIV infection in young women remains a challenge to the global pandemic. We're never going to achieve HIV control unless we can change that trajectory. Data published in several studies recently, we've seen in the Lancet and other journals, have been showing that there's been a steady decline in new infections in Africa, but one group has remained refractory. We have not seen those declines in young women in several countries in Africa. And to give you just some idea of that burden, on the right-hand side, look at the orange bars. That when you're looking at young girls in this large community-based study, a representative study of the community and HIV prevalence in the community, already by age 15, 6% of young women have HIV. And when you go to age 30, the prevalence is all the way up to 70% in a representative sample. So giving you some idea of the sheer burden of HIV, particularly in women, and high rates in young women being central to that. So what are we hoping that we will be able to use to turn that around? Well, pre-exposure prophylaxis. We have seen how PrEP has been steadily increasing across the globe, particularly in Africa, driven by the DREAMS programs and country programs that have been introducing PrEP. We've seen the benefits of PrEP, and here I'll use the example of PrEP in men who have sex with men in San Francisco. Well, a dramatic impact. We've seen a 43% decline in new diagnoses in 3 years. However, the sad tale of PrEP in Africa has been somewhat different. What we have seen is the first early adopters of PrEP in Africa have largely been serodiscordant couples. That makes sense. These are individuals who recognize their risk. But even in that group, we have seen difficulty in sustaining PrEP. And so we have been seeing high fall-off rates from PrEP, even in serodiscordant couples. Unfortunately, we are not seeing adequate uptake from young women. And the issue is very simple. In order to take PrEP, you firstly have to recognize that you are at risk of HIV. You then have to recognize that the PrEP is something that would benefit you in addressing that risk. And then, of course, you've actually got to go to the clinics, have access, be able to get there and get the medication for PrEP. Those three requirements are onerous, especially the first, that for young women who don't see themselves at risk of HIV, PrEP will be a real challenge in getting high coverage in that group. And so we're going to have to think about this differently. We've got to think about a new paradigm for PrEP. PrEP needs to shift from a user-initiated approach and provision. And we've got to move to a whole new strategy of a provider-initiated service, where PrEP becomes the norm for communities at high risk. Just think back initially in PMTCT, how low uptake we had for HIV testing in pregnant women, until we shifted it from a provider-initiated testing approach to a user-initiated testing approach to a provider-initiated, where it became the norm that when you walked in and you were pregnant, you were going to get an HIV test and you were going to get PMTCT medication if necessary. We have to shift our thinking about PrEP along those lines. And we're going to need new technologies to do that. We're not going to be able to have provider-initiated approaches if we have to see people on a monthly basis or 3-monthly basis. We have to move towards technologies that will last at least 6 months, if not a year. But we've seen improvements. We've seen how we've got safer alternatives for daily oral PrEP. We're now seeing monthly injectables and 2-monthly injectables. We're seeing a monthly ring, possibly even going up to 3 months. But what we need are longer acting technologies. And thankfully, many of them are currently under study. We ourselves are looking at a 6-month approach with broadly neutralizing antibodies. There are others looking at different approaches. So how are we going to look at this? How are we going to look at HIV control in the midst of COVID-19? Well, 3 key challenges. The first is attention for HIV is declining. In this global survey, the #1 challenge that people around the world were seeing in 2020 was the coronavirus. It eclipsed unemployment, poverty, political corruption, all of those. So COVID-19 has taken center stage. HIV has been shifted to being in the sidebar. We've also seen how COVID-19 and its impact has impacted HIV services. We've seen here in South Africa, in papers we've published in Science and in Lancet HIV, we've shown how HIV testing was compromised, but all of those impacts were short-lived. And we've seen how we've been able to recover, and antiretroviral treatment has now gone ahead. We've seen how in severely immunocompromised HIV patients that new variants are being created. In this particular example, this individual developed several mutations in the spike protein, and 3 in particular were the same mutations that we see in the beta variant. So new variants are going to continue to arise from immunocompromised individuals. Individuals included in those are not just transplant and cancer patients, but severely immunocompromised HIV patients. So we've chosen our path. We've chosen a path that involves using treatment as the foundation for our overall approach. And we are now going to need to see how are we going to move the next level. Getting to 90, 90, 90 and 95, 95, 95 simply gets us to base camp. We still have a long way to go to get to the summit, and we're going to need to be flexible. We're going to need to deal with these challenges with new benefits. And a successful climb to the summit is going to need at least these 5 key ingredients: translating new science into community impact through knowing your epidemic, knowing your response, targeting it, as you see in this picture from KwaZulu-Natal, community engagement, addressing inequalities as part and parcel of our approach, doing things with people, not on people, but we're going to have committed leadership. We've been fortunate in some parts, sometimes during this pandemic, that we've seen that kind of committed leadership. And we know the importance of global solidarity. But we're going to need a bold, evidence-based plan to move us beyond our treatment targets. And that bold plan has to be a global response that I'm simply going to refer to here as TASP+. It's going to go beyond just treatment as prevention, with 3 underlying principles: addressing vulnerable individuals, leaving no one behind, an evidence-based set of strategies, and effective implementation, especially targeting priority areas. And the 3 key components of this plan is a recommitment to ensuring we continue the rollout of treatment, but we need to move beyond our targets of 95, 95, 95. We're going to have to go concertedly on a provider-initiated PrEP program, and we're going to have to bring a combination prevention tools as we are needed in each setting. This HIV prevention toolbox will have 2 key tools: treatment, PrEP. But it's going to have to build all of the other tools that we have, we know that are effective. So building on ART and provider-initiated PrEP, we're going to have to maximize the benefits of combination prevention. That we have to be bolder in thinking about how we're going to tackle HIV in the upcoming years to achieve the UN target of 2020 of controlling HIV and ending AIDS as a public health threat so that it remains just an endemic infection. Thank you.
Well, thank you so much, Professor Karim. Thank you for that excellent speech to round off our presentations today. I've been really struck throughout all the talks by some of the themes that have been that I've seen emerging through the talks, such as how far we've come with HIV, the wonderful advances in science and the tools that we have available to us today, but really getting back to the theme of today's session about ending inequalities. The need to get those tools to where they're really needed is key to advancing the fight against HIV and AIDS. Now, throughout the talks, people have been submitting questions. People can, I believe, continue to submit questions during this moderated discussion. So please do use the live question bar. But I think we can now perhaps start with some of the questions that we've got for you. I'll start with a question for Peter Piot, if that's okay. So in your presentation, Peter, you underscored the importance of leadership dedicated to HIV and AIDS. Could you please elaborate on that and why dedicated leadership is still key?
Thank you, Peter, and thank you to all the presenters. I really learned a lot, and I couldn't agree more with, with Slim in the last presentation, that we need to go where the people are, and we need this kind of new strategy, building also on what Adiba said of the based on science, but innovation will come. And so that means that the toolbox may become more efficient, or because from daily prep to 4 times a year, who knows? So leadership, why am I insisting on that? Because for a few reasons. One, take just the last presentation and what Slim said. In order to implement that, you need leadership to make sure that it's not only official policy, but that it's at all levels. There is accountability. As we also heard, from the community, that there is money. Without funding, you can't do these things. And sometimes, you need to take unpopular decisions. And I think Adiba's point about harm reduction is a case in point, that this requires leadership that may go against popular sentiment, but it's evidence-based. And we've seen that in the past, and that's where I'm quite worried that AIDS is off the political agenda, but it's not only political leadership. There's scientific leadership, technical, community, and at all levels. Thank you.
Okay, thank you, Peter. And then I suppose one to follow on from that, if I could ask George Gao, because you also mentioned leadership in your presentation. You've shared with us the amazing progress that China has made in response to AIDS and the importance of accountability and leadership at every level of government. If you had the opportunity to speak to leadership in Africa, what advice would you give on ensuring that even as we deal with COVID-19, how do they not drop their focus on HIV and other key diseases for the region, such as tuberculosis?
Thank you. I think you have already seen recently we have the new virus, new variant of the COVID-19, the Omicron. So at the moment, all the scientists and public health workers thought it might be arriving from HIV population, because circulated. I think Dr. Karen will give a more clear view about that. But in my opinion, because of that, and you give a chance for the virus to mutate. So this is why the community level capacity building is very, very important. I said in my slide, I want to add a little bit more for Peter's point about the political will leadership. In China, political will leadership, they encourage to invest a lot in the community level for the capacity building in China. You are right. I traveled to many countries in Africa, so I found the community level facility or capacity is a problem there. So, and even when you are talking about anything, even in the developed country like in Europe, where Peter lives, or in America, so previously you have very good community level capacity, because you are a kind of a developed country, and you forget for the public health, the community level is very important. For example, I remember from the very beginning, even in some countries like in Ireland and even the UK, the community level nurses are not there. So because we have the SARS, we experienced the SARS for the last decade, we spent a lot of money for the community level building up the capacity. So in my opinion, the lack of the community level capacity for the public health, that is in both the developed country and the developing country, including Africa. And the developed country, because they never thought they have the problem with disease like and the public health problem like the COVID-19. So they ignored the community level diagnosis, including for example, nucleic acid the test at the moment. In China, we can't do that just because we experienced SARS decade ago. Otherwise, we also have the problem. So this is why I want to address more. Again, First, political will, leadership, focus on more community level base. And second, invest your money in the community level, not in the central level. Thank you. That's my comment.
Great, thank you very much. And I think sort of it would be nice, following on from that, since you've just been talking about the community, if we could bring in Sibongile to talk about, because obviously leadership isn't just governmental leadership, but leadership also comes from the community. And I wonder, Sibongile, if you've got any reflections on leadership and the role of community.
Yeah, thank you, Peter. As everybody says that the community leadership is very important. We should learn from what was happening in South Africa in the early days, around 1998 to 2004. It took communities to take leadership, to fight the government of South Africa, to be able to initiate people on ARVs. So that is a lesson to say, as communities, we know best. We know what is happening in our community. And as much as South Africa has a biggest rollout on ARVs, it took leadership from the community to give information to communities, to simplify the science of HIV, and also to be able to understand what is happening in the community and how to address issues of HIV in the community. Community leadership is very important, and we shouldn't ignore it, because at the end of the day, we are seeing more problems because people on the ground, we know best what is happening and we know best how to respond to these issues because we are living in community. We engage with communities every day. So we are a very important role, and that is what is very important. But lastly, Peter, I just want to say we also need a political leadership from the ground, because what is happening mostly in South Africa, you won't see what councillors being in the forefront of HIV, your premiers, your mayors are not in the forefront of HIV. We see less of commitment from that political leadership. So when we are talking about community leadership or leadership, we are meaning at all levels, from the community side and the government side. Thank you very much.
Great, thank you, Sibongile. I think that really tied that subject up nicely and brought it back to the original question to George. So I think we might move on now to some of the more sort of scientific or clinical aspects, I guess. So a question here for Adiba. You very eloquently captured the centrality of science in enhancing our response to HIV and SARS-CoV-2. Including new scientific advances and how they're involved in prevention and treatment. And you identified rightly the challenges of implementation. What are your thoughts on equitable access to some of the new innovations so that these expanding options become real choices for the populations who need them most?
Thank you very much, Peter. Well, I'll just start off with, in terms of access to the COVID vaccine. Now, the world is learning how painfully the inequities in vaccine rollout is affecting the entire world. But going back to HIV, the inequities there, it can be within countries, but also globally in terms of access to these tools. HIV has traditionally affected people at the margins, and unfortunately, I think in terms of government priorities in financial investment, especially with domestic funds, people who inject drugs, MSM, and sex workers and transgenders may not be high on the priority list of governments in investing health dollars. So, and certainly we see that happening in many parts of the world, and hence I think, despite us having all these tools at our disposal, we're still struggling to get them to where it's most needed, as Peter Piot very nicely put. So, we've been living through this for the last 2 decades. We have great tools, and yet it's not going in many places to where it's most needed because of this inequities. Underpinning all that is, of course, stigma and discrimination, criminalization of behaviors that has plagued the HIV response for many years.
Great, thank you. And now let's come to Slim, if we may. So you mentioned in your talk about provider-initiated PrEP as part of the TASP Plus approach. Can you perhaps elaborate on what that is and what that entails at a practical level?
Yeah, thanks very much, Peter. I think as we reflect on what is a new and important tool that is becoming available for HIV prevention, we have to grapple with the next step, which is, what's the best way to use that tool? Well, you know, in a very traditional medical model, the way in which we'll deal with that would be to simply, you know, invite people to say, you know, here's a new prevention mechanism, you know, come and get it, it's available at the clinics, and we do promotion of this with information. I think if we take that approach, that we will see PrEP simply become a niche prevention product. It will only be attractive to those individuals who will take it up because they see themselves at immediate risk. As we're seeing in Africa, in the bulk of the first batch of uptake, it's in serodiscordant couples. So to change that, we've got to take that out of a medicalized setting, and we've got to look at it at a more community-based setting. So let me give you an example. In the community in which I outlined, I showed you what the HIV prevalence is in that community. You saw that at age 30, you know, about 70% of women are already positive. In that kind of community, you've got a large part of the population already on treatment. Well, the remainder who are at risk of HIV, they should be on PrEP. And one of the key populations to get to, one of the key groups that need PrEP is young women. So if we had a 6-monthly or annual technology, what we could be doing is going with a mobile service from school to school to school. And when we get to school, we, with consent, invite all of the girls within the risky age range from 15 to 24, 15, above 15, and they are offered PrEP. It's a pretty standard, it's driven by the provider. And that approach would mean we'd have a large number of young women covered very quickly, and we'd be able to sustain that because they don't have to remember in 6 months' time to take another injection, right? Because the mobile is back to give the next dose. So I think at a practical level, in high-risk communities, that we could make a big dent to the number of new infections through this kind of approach.
Great, thank you very much for that. And actually this, again, I'll follow on with you, Slim, here actually, and then maybe come to other people on the panel. How do you think that sort of expanding options for pre-exposure prophylaxis, how can those choices be targeted at the people who remain most at risk? Do they provide new opportunities? Oh, Slim, you're on mute.
I'll just touch on that issue. I think my colleagues in George and Sibongile will have good perspectives as well. But I think as we think about a technology like PrEP, high coverage is essential for benefit. It's like vaccines. To get the real benefits and the full benefits of vaccines, you've got to get to high coverage. And PrEP is exactly that. Unfortunately, one technology is not going to suit everyone. So the more options we have, the more we have a chance of increasing coverage. In other words, we get, horses for courses, because individuals who prefer a tablet can take it, people who prefer an injection can take it, and so on. So I think that's where it'll make a big difference.
And okay, so PC, you have something to say
Yes.
about that?
Thank you. No, I think this is a really important discussion, and where we move from let's say a theoretical centered concept to one that's about people, but the first point is that you need to know where your epidemic is and where transmission is, and that's where some of the really the beautiful work done in by CAPRISA, but also in China, in several places, in Kenya, for example. If you don't know really, and by knowing, I don't mean just assuming, but you have to document it, because sometimes we're wrong and in our assumptions. So, and that's what we have the tools now with pretty sophisticated genomic sequencing and so on, plus working with people in the community, because they know. Sometimes you don't need that sequencing, because if you just talk to people, but yet it should be really together. And then that's the next step is and I'm not talking about years, this is something that can be done rapidly and should have been done quite a while ago in any case, but then organizing the offer in function of if it's young women, okay, you think through where are people going. One of the reasons I mentioned like sugar is that, we've been hammering young people with messages about don't do this, don't do that, and so on. But you need to use the media, their role models, what appeals to them. And then thirdly, I think Slim's point about options is really important. Think of contraception is the same thing. It's not just one approach for family planning, but you need to have options in function of people's realities. And these realities are different from one person to another. So these are some of it, but it's really, it hit my brain about, offering PrEP in health services. You can have very high, take-up, but it's irrelevant. I'm not saying irrelevant, but it's not going to have much of an impact on the epidemic. And Slim, you recently wrote an op-ed on that, a comment. And that's where we need another argument to combine the basic science and working with people in the community. That combination can be really powerful if we translate it into service provision and go where the issue is. It's the same for vaccination. We're stuck. The easy part is, the beginning. And then what they call the last mile is usually a last 1,000 miles with lots of problems. And that's what we are. I mean, it's nothing new. It's just to use common sense. Thank you.
Yeah, last mile is the hardest, isn't it? Sibongile, I wonder then, since we were talking about sort of community engagement and communication, if you have any thoughts about how we get new innovations, be it PrEP or whatever, to the community.
Peter, I think the mistake that we are making now, all of us scientists, governments, and activists, it's not asking, especially when we talk to young people and when we send these messages to young people, we don't involve them in the first planning and to understand what are they going through, what are the issues, how do we address these issues. I have listened to, if you can look at the panel here, most of us, I believe that we are over 40, we are most experienced, but where are the young people? Because the young people, they know their challenges, they know what is happening, and they have put in innovative ways of dealing with their issues. So what we need to do now, as all of us, as scientists, governments, activists, is to get young people to be involved, not just to be part of us, but they need to be implementers, they need to be decision makers, they need to be initiators, and we need to listen to them. I think if we can get it there, I'm definitely sure that we will get somewhere.
Great, thank you. And with my eye on the time here, I wonder if we could just come to Adiba and George in that order briefly to get their thoughts on this topic. Adiba.
Yeah, I actually had my hand up to expand on what Shivangile just said. I think we scientists often forget to include the community in the original design of research, which can help us a long way in designing, research that matters, and in designing research that will work. For example, in the use of digital technology innovations that sometimes, are designed by computer scientists, let alone, clinicians and end users, as well as communities. So I think to expand on what George said, one of the 4 C's, collaboration and communication, are essential in designing science that matter, and making sure that whatever tool we come up with are going to be effective right from the get-go.
Great, thank you. And George, did you have anything to add on this topic?
No more comments from me. Thank you.
Oh, great. Well, thank you. Well, I think we are coming towards the end of the session today. I'm sorry if we didn't get to your questions, or if you've got other things that you would like to ask. We've just run out of time, but I think that discussion there was interesting, and it was nice to hear from everyone there. So it's been a fantastic session. I've really enjoyed all the talks today, and I think there have been some interesting themes that have connected everything. I've just got a couple of more duties to do. Firstly, I'm going to hand over to Professor Menji Han, who is the director of the National Center for AIDS and STD Control and Prevention in China, who works on implementing a comprehensive HIV response as a researcher for the Chinese Center for Disease Control and Prevention. Menji is going to sum up with some sort of concluding remarks. Menji.
Thank you, Dr. Peter. Good morning, good afternoon, good evening. I'm extremely delighted to join the webinars to commemorate the World AIDS Day 2021. I would like to thank Professor Salim and Professor George Gao for the initiation and planning of this event. And it's their professional reputations and achievements that enable us to engage our other distinguished scientists and activists to join this webinars. I'm sure that all of us very much enjoy and learned a lot from knowledges and insights shared during the webinars. In the past 4 decades, since the first case was reported, more than 30 million people have lost their lives to HIV/AIDS. Currently, is 37.7 million people suffer from the HIV/AIDS. In the fight against the HIV/AIDS, we have invested enormous effort, the great wisdom, and substantial financial resources. Through this, we have made a great achievement. And particularly in Africa, with the highest HIV burden in the world, this struggle has been extremely hard and bitter. It deserves our respect that Africa has achieved remarkable outcomes in HIV/AIDS, and with a significant decrease in the new infections and the mortalities. China is the greatest population country in the world. The Chinese government has adhered to the principle of the people-centered and put the people and their lives first. The HIV/AIDS response is one of the most important items on the government agenda, for which the enormous resources and invested. Has made a great achievement. And you have learned from the presentations by Professor George Gao And this year's the UN General Assembly reaffirmed the commitment towards ending the AIDS epidemic. It's opened a new chapters in fighting against HIV/AIDS. However, the COVID-19 pandemic has been jeopardizing our effort. The epidemic is still raging with the emergence of new variants and tremendous challenge ahead of us. We have to continue our fight against both COVID-19 and HIV/AIDS at the same time. And we need to draw from the lessons learned from the past and continue with our new commitment. Some of the views I would like to share with all of you. And firstly, and put human life and health first, and increase the investment that leave no people living with HIV/AIDS and people who are vulnerable to the HIV/AIDS behind, and ensure that everyone has equal access to the HIV/AIDS services. Secondly, to make full use of the science and technology and translate into the science and technology to the community, to strengthen the scientific research and innovations in the medications interventions to provide the strong support for our response. Thirdly, the strengthen the unity and the cooperation. We are a community with a shared destiny. We must unite and work together to strengthen the knowledge and share experience and cooperation, just like we have done today. Finally, and mobilize the full participation of all societies with the communities and the public engagement to eliminate the stigma and the discrimination that people and living with HIV/AIDS or the people vulnerable to the HIV/AIDS in the often experience. It's my belief that as long as we adhere to global solidarity and shared responsibility and ending inequality, ending AIDS and ending pandemic will be achieved as soon as possible. Thank you so much. I very much enjoy the webinars.
Thank you, and so did I. I again would like to reiterate my thanks to CAPRISA and China CDC for organising this and for inviting me to moderate today. It's been an absolute pleasure. And I'm now just going to hand over finally to Research Powerhouse and Associate Director of CAPRISA, Quraisha Abdul Kareem. Thank you.
Thank you very much, Peter. Greetings, distinguished guests, friends, colleagues, and everyone who's joined us in this amazing past 2 hours for such a stimulating, inspiring, provocative webinar. And it's my great delight and pleasure to thank the many people who've been involved in ensuring this webinar happens, starting with the China CDC, the Chinese Embassy, CAPRISA, our wonderful moderator, Peter, our amazing speakers, all the way from starting off with Adiba, Peter, John Kengasong, Sibong Yile, Slim, George, and all of you for taking the time to participate in this webinar, the many technical staff who've worked behind the scenes from each of the organizations. And I just wanted to spend a minute on our speakers. I think that many of us are still reeling from Omicron and trying to, we thought we're going to have a nice, quiet Christmas after 2 years. And the thing that's striking is that each of our speakers is not only involved in HIV, but playing a pivotal role in COVID-19. And so they've each reminded us about the importance of solidarity. And we've seen how solidarity and global solidarity has enabled us to accomplish so much in an unprecedented way in HIV, that our accomplishments in COVID, in a way, has been facilitated by these investments in HIV, in TB, in Ebola, in coronaviruses in general. And so while we celebrate and remind ourselves of great success and progress in the HIV response, we've also been very sharply reminded this is not an epidemic that's over, and that we have to keep our eye on the ball, and that we're going to face in this next decade or more, many more pandemics, and we cannot afford to drop the ball and have multiple incomplete pandemics or epidemics. And how do we, again, join hands at every level to ensure not only that we put HIV, TB, and COVID behind us, or as Peter has reminded us, it may not be completely out of our life, but can we get it to levels of endemicity that enable us to normalize this in our lives? So thank you, stay safe, stay well, and wish you the best over the holiday season as best as we can under the circumstances. Thank you so much.